all the chairpersons on the dais. I would now request the chairperson to introduce our speaker for the first oration.
Good afternoon, everybody. It is really a proud privilege to hear my student. He has already said mother of my academic mother. I am so proud of you, Sandeep, and you are giving today's oration. So really, I want all my students to prosper. I have seen Dr. Mukesh also, Patel. He has also come all the way from Mumbai. He is also my student, and there are many more students. So when the students prosper, the teachers feel they have achieved many, many things. So with this, I would like to talk about Sandeep, that he is a very, when he was a resident of mine, that time he was a very nice, dedicated, sincere person, and he has not changed, madam. He has just remained the same, and I am really happy that he has achieved in his life as a laparoscopic surgeon, IVF specialist, and he is progressing very well. So I am very happy, and of course his wife Nidhi is supporting him all the time, and that's why he can do so much of work. So he is a director of Icing Hospital and Parvati IVF, director of Milestone Hospital, Nagpur, India, consultant, laparoscopic and pelvic surgeon. He is a president NOGS Nagpur, member of FOGSI Endoscopy Committee 23-24, invited member FOGSI membership cell, won FOGSI Dr. C.S. Don Award at AICOG Kolkata 2023, winner IIG Annual Conference Endoscopy Video Award 2021, winner Dr. M. Rohatgi Award for Endoscopy in 2020, organizing secretary of IIGA Gynecology Laparoscopy Live Workshop 2016-2022, performed more than 15,000 laparoscopic procedures, operating faculty at various national and local live operation workshop. And I must also say that I had come for his inauguration of his hospital, and it was a lovely experience and memorable experience. Now, Sandeep, dais is yours. We would like to hear from you.
Manjula, do you want to say something?
I think so much has been said about him. I don't think I can add anything more than what Dr. others have spoken. I don't want to waste time. I think he's an excellent person. I have met him from the first time in Menopausal Society conference in Bombay. And since then I thought he was a little person. But now he's really grown and known so much more than what I know him before. And he has progressed and progressed and progressed. That's all. Thank you so much.
I don't know Sandeep for long. I know Sandeep through Indian Association of Gynae Endoscopy, and we got to be close. And it was a privilege to attend Sandeep's installation also. But I think I take great pride in being a great host. Me and my team, those of you who've come to our conferences. But Sandeep is a great host. Last night when from the time that he speaks to me, he's been worried about that my flight will land at 11 and where I'll have dinner. Till such time I tell him, don't bother. And yesterday when mine and Hrishikesh's flight is delayed, he was wondering whether he should order some food and put it in the room. To the extent we said, do not bother, we will fend for ourselves. Thank you, Sandeep. I think these are great qualities and these small things matter. The stage is yours.
Thank you so much for those kind words, sir. So, good afternoon, everyone. In the morning, my friend Mukesh came from Mumbai, and he asked me, what's your topic of oration? I gave him the topic list, and he said, how are you going to repair your wife? Because he hurriedly read that, and he said, how are you repairing your wife? I said, that it's not my cup of tea. Just read it properly. It's a repair of life of a silent sufferer. So this is a story of a village girl who got married with a nice husband, a caring husband. After a few months, when she got into labor, She was surrounded by all those dyes. All they were trying hardly, giving some juices, but she could not deliver. Her husband got worried. He could not take the decision. He asked his elder person, and by the time it took overnight, the next day they decided to go to a hospital by bicycle. They reached to the hospital, and doctor told that the pelvis was inadequate, so she has to undergo cesarean. But she had IUD. In addition to that, doctors told her that she got fistula. She was leaking continuously. Even her husband left her. Her mother also don't want to accept her in her family. So she was staying alone outside the village. Even the villagers are not accepting, and they are telling her to stay away from village. So she got the option of begging. And few men also take the advantage of a single woman, but even they left her because of the bad smell. Yes, I'm talking about the obstetric fistula. There is a quote by Levi's that every minute a woman dies in pregnancy or a childbirth, and for every woman who dies, 20 to 30% others will survive, but with some morbidity, and that morbidity is obstetric fistula. So what is the global burden? Obstetric fistula remains a significant obstetric problem in low resource countries. Mainly these continents like Middle East, North Africa, East Asia, South Asia and Sub-Saharan Africa got 1 to 3 deliveries, 1 to 3 patients of fistulas every 1,000 deliveries. An estimated of 50,000 to 1 lakh people women are got this with fistula, obstetric fistula, and every year almost around 50,000 added on in that tally. What is the burden in India? UNFA in 2003 report indicated an overall fistula prevalence of 2.2% in India based on the community survey. The obstetric fistula is still largely neglected in low resource countries and developing world, especially in India, where women's health get compromised due to poor socioeconomic status of the community. Historically, if you go back, the earliest example of obstetric fistula was found in 2050 BC in Egypt, where an 11th dynasty mummy, Enith, appears to have a VVF fistula. So this is that lady, Enith. The relationship between the obstetric labor and fistula was first recognized and described by a Persian physician, Avicenna, in his famous book, The Canon of Medicine. The first repair of VVF was demonstrated by Henry Van in 1676. And this James Marion Sims, whatever he was using in the Sims speculum routinely, that he was the first person to repair a VVF on a slave woman. Coming on to the etiology of obstetric fistula, most common cause for this obstetric fistula is the prolonged obstructed labor, spontaneous abortion, cancer radiation treatment, poorly repaired episiotomy. That I will show you in a few minutes, that how that poorly repaired episiotomy can lead to rectovaginal fistula. Coital trauma. I am lucky to got this. As a doctor, I am lucky that I got a patient who got coital trauma on the first night of that couple. Infection with the lymphogranuloma venereum also can lead to this obstetric fistula. If you go through this bar diagram, this 29% of the cause is because of the provider's fault. That means we are, as a doctor, are at fault of not providing the proper and the health system, whatever we are standing in between. So these are the risk factors like lack of emergency obstetric care, place of birth, presence of skilled birth attendant, duration of the labor, women with no antenatal visits. If the patient doesn't have zero antenatal visits, women who delivered at home, lack of decision making in the emergency situation, delay in receiving care more than 6 hours of the labor onset, taking more than 2 hours to reach the health facility. Now this was removed right now because of the excellent transportation system in our India. But then the long duration of labor also can leads to obstetric fistula. Coming on to the pathogenesis, when labor is obstructed, the presenting part of the fetus advancement is prevented by presence of the unyielding bones of the pelvic girdle. The uterine contractions relentlessly compresses the entrapped soft tissues of the bladder, vagina and pelvis, eventually shutting off the blood supply. The entrapped tissues die and slough away, creating a fistula between the urinary tract, rectum and vagina, through which urine or stool leaks in a continuous and unremitting stream. So there should be some classification that how to deal with the such fistulas. They are mainly they are divided into vesicouterine, vesico-vaginal, urethrovaginal and rectovaginal fistulas. But there are two systems like Gold's classification and Wald's classification, which help us to identify the number, the depth, the length of the size of the fistula, the urethral, this situation, location of the fistula from the external urinary meatus. Now, how they present? They present with the continuous leaking of the urine through vagina, foul smelling or vaginal discharge, incontinence of the flatus also. And they have presented the incontinence of the liquid stool and perineal itching. But the worrisome is that a study reported that women with the fistula symptoms also reported the experience of sexual and physical violence much more often than women without such symptoms. So this is more worrisome. What are the complications of fistula? Uterine rupture, uterine scarring resulting in the secondary infertility, amenorrhea and dyspareunia. Because of the compression of the fetal head on the pelvis and pelvic girdle, there may occur the foot drop because of the compression injury or ischemic damage to the perineal nerve. The involvement of the L5 root is often noted, and severe pelvic ischemia can lead to post-delivery paraplegia also. There may be renal damage, like in a 4.6% of patients presented with the bilateral renal shutdown, complete renal shutdown, 34% have the bilateral hydroureter and 48% have some renal damage. These are the dermatological complications of the skin excoriations, ulcerations. The emotional and social impaction is more dangerous, that they got stigmatization, isolation from the family, isolation from the town and loss of social support. They can't earn money. They are hesitated to go to the market, to working place. They may get divorced, and because of that all this poverty and malnutrition and premature death also. Now, how to diagnose the fistula? So diagnosing fistula is not that much difficult, but you can see that history taking is more important. That is, what is the onset, duration and description of the leakage, history of concomitant stress and obstetric history including the mode of delivery, underlying risk factors and sexual history. On physical examination, the two position, that is Sims position and lithotomy position, is mainly used. You have to palpate the anterior and posterior vaginal wall and feel the fistulous tract. There is a click test. When a metal catheter when bladder gives click when metal probe passes through vaginal orifice of the fistula. This is a patient which presented, I had operated a few days back. She was taken for LSCS, but the catheter was not going into the bladder and it is come out through just below the urethra. So this will tell you that she may have a uretrovaginal fistula. Again, you can go for the cystoscopy and put the ureteric catheter, and that catheter will come out of the vaginal vagina, and you can diagnose the vasacovaginal fistula. And you are all doing this 3-step methylene blue dye test. I will not go in detail of this. There is a modified methylene blue dye test. You put the methylene blue dye in a bladder and you can actually see the location of the fistula. Radiologically, you can go for the cystography by using a diet. You can go for the cystourethropy. So, when to operate? The preoperative evaluation must be there. At the timing of the surgery should be proper. They said that once there is a fistula formation, you should have to wait for almost 3 months. But in my practice, what I found that if you diagnose that fistula in the early phase, say like about 8 to 10 days, then is the earliest time that you can operate that. And whatever the surgeries I had done, they are mainly presented with me in 8 to 10 days, and this gives the 100% result that without any incontinence in future. So which surgical approach? You could go for the vaginal, abdominal or combined approach, or the recently the laparoscopic approach for the vasacovaginal fistula. Now coming on to the surgical management of the uretrovaginal fistula. So this is the case I recently, just a few minutes back, I told you about the examination. During the examination, that he was posted for emergency LSCS because of the CPD and with history of previous one LSCS. Dr. Nidhi inserted the Foley's catheter. But that the catheter was not going inside the bladder. It was coming onto through the vagina. So I thought that this is a uretrovaginal fistula, and we go ahead with the LSCS. We did the LSCS under the regional anesthesia, and then in the same setting we started operating. The first and basic step is the refreshing of the circumferential edges of the fistula. Don't bother of the bleeding. I love the bleeding at the fistula's tract because this suggests that the underlying tissue is healthy. You just have to remove the scarred tissue. Once the refreshing of the circumferential incision edges of the fistula are done, here actually you can see the Foley's catheter. Can you see this? Now this urethral epithelium is then sutured with the 2O polygalactin suture intermittently. And then the tubocervical fascia was approximated, and lastly this anterior vaginal defect was then closed. Post-operatively, we observed her for almost 6 weeks now, and she was without any complaint. During her ANC period, not at a single time she told that she had leakage, and that is the point, because nobody wants to discover or nobody wants to tell the even her husband or even family members that she is having fistula or she had some leakage problem, because she don't want to, or that lady don't want to give an extra burden of monetary burden or any psychological stress to her husband or her family. So that is the reality of now also. This is another patient of surgical management of rectovaginal fistula, but before that I would like to highlight some anatomical points. This will help you in day-to-day episiotomy closure also. We all know that posterior vaginal fourchette and this anus, there are two important muscles, that is bulbous spongiosum here, then the superficial and transverse perineum in the middle, and then the anal sphincters. So the anal sphincters are two, that are the external anal sphincters and external anal sphincters. This is the external anal sphincters, which is the striated skeletal muscles, and this is the internal anal sphincter, that is the continuation of the longitudinal muscles of the rectum. So to understand this anatomy of this is that you have to close this internal anal sphincter. If you don't close it properly, then the patient will have liquid or solid incontinence in future. If you don't close this external anal sphincter, she will have incontinence of the gas, or that is flatus. So if you close your episiotomy for the 4th degree perineal tear and patient presented with excessive flatus, just think of that you are not closed this external anal sphincter properly. And this is the main highlight of my talk, that you should close this episiotomy, because day and night we are closing this episiotomy, right? So just watch this video. This is a patient which was referred on day 6 of the delivery. On speculum examination, you can see the catgut. I put my index finger into the rectum, and that finger came out to the posterior vaginal wall. Again the same principles, that is circumferential refreshing of the rectal mucosa. So I am doing here circumferential refreshing. Now you can see the proper, this is the hole. So now this rectal mucosa is closed with the 2O polygactin suture. You have to close this with the continuous fashion, or you can take it intermittently also. You have to irrigate the local tissue continuously so that the vision will be proper, otherwise you will miss it. After the closure of the rectal mucosa, next step is the closure of the internal sphincter. Now how to identify the internal sphincter and external sphincter is a big task, because all there is a mess. But what I learned from this is that internal sphincter will look like a fish meat, and this external sphincter muscles, they are look like a red meat. So just imagine that you are having a red meat on your table, and on the other side you are having this fish meat. After the closure of the internal sphincter with the PDS suture, now I am closing the external anal sphincters. After the closure of the internal sphincter, the posterior vaginal wall apex was then closed, as we routinely do in episiotomy. Each time you have to refreshen the edges of the wound so that you will get a healthy tissue to approximate. Now I am closing this bulbous spongiosum muscle. Approximation of the bulbous spongiosum muscle. Then the transverse perineum and the external anal sphincter complex. After that, you have to approximate the episiotomy wound, as we routinely do, approximation of the skin. So this is the end result. Always do go for the per rectal examination to identify if there is a leakage or not. So how to take the post-operative care? You should have a high fluid intake, 4 to 5 liters a day. Blocked catheter. Sometimes if you put the catheter for the vasovaginal fistula, then it will be an emergency and you have to flush it with the normal saline. Transurethral drainage catheters are generally kept for 14 days. Police catheter should be removed without clamping. We got a habit, or our seniors told us that you to do the clamping and then feel the sensation of the bladder and then go. No, there is no need. Now neurosurgeons are not advocating that. Women are advised not to resume sexual activity for 3 months, and failure of fistular repair must be ruled out, and incontinence should be asked after 3 months. Antibiotics should be continued for 2 weeks, and always give muscarinic antagonists like solifenacin for 3 to 4 weeks. So there is a statement from the surgeon that the smiles on the faces of a woman who received surgery for the VVF or any rectovaginal fistula, and where they are cured, their fistulas encouraged me greatly to learn and practice this type of surgery. There is always saying from our old senior gynecologists that the sun should not rise or set twice on a woman in labor. So that is the main advice from our seniors, that was madam, and as Manjula madam also told that repeatedly to their residents during their post graduation. So how to prevent this? The primary prevention includes delaying the marriage, because most of these fistulas are happen in the 14 to 24 years of age. Till now in Rajasthan or some states, this child marriage is going on, and most of them they conceive on at the age of 15 years or 16 years, and then the problem starts. Adolescents malnutrition, if you give the vitamin D properly to your girl at the age of about the age of the 16 years, then their pelvic girdle will be strong. Secondary prevention, this is the main part, and you have to follow this new partogram, that this will help you in identification of the patient for the obstructed labor, and early transportation by ambulance is the key for the prevention. Tertiary prevention, creating a SOP at health centers for management of the women who have survived prolonged or obstructed labor, early recognition of developing or developed fistula, and surgical management at a proper center and to an experienced surgeon, and post-operative rehabilitation of that patient. As we are growing with advanced technology and well equipped with resources for providing quality maternal care, this is the high time it should be eradicated. That this fistula's condition should be eradicated from all parts of the country, for which community sensitization and community stakeholders is essential. So for that, WHO has started this International Day to end the obstetric fistula, and it comes on the 23rd of May of every year. So at this moment, I request you to place for the eradication of the obstetric fistula by 2030. To conclude, I would like to say that the prevalence and risk of developing obstetric fistula was associated with less number of antenatal visits, prolonged labor, delay in timely intervention, delay in assessing emergency obstetric care, more number of movements from home to the delivery place, timely intervention during labor, timely referral will prevent the obstetric fistula. The early diagnosis and proper surgical technique will cure the condition completely, and community education and role plays will help us in eradicating the obstetric fistula by 2030. So on this occasion, I pledge you to eradicate this obstetric fistula by 2030. Thank you.
Sandeep, it was an excellent deliveries. You have taken us to the journey from the normal level to the fistula, and how we can prevent this urinary fistula as well as the rectal fistula, and that is very important. We used to see many fistulas in our residency days, because those days the cesarean sections were very low, and we used to, because they were not that cesarean. So the patient were given a lots of trial for vaginal delivery. We used to see many fistulas, especially uterovaginal fistulas. And you know, the repair was done immediately. If you don't do repair immediately, then we have to wait for at least 12 weeks to repair it. Those were the days over at that time, because the reaction, the tissue fibrosis, whichever it occurs, then we had to wait for 12 weeks. And then, you know, once you do the repair at the same time, when you diagnose this fistula, then it is a different matter, you know, immediately we do. Sometimes the cesarean section following, especially deep transverse arrest and obstructed labor patient, when you do a cesarean, that time the fistula can occur later on after 10 days of cesarean because of the ischemia. So those are also very difficult to suture. Many times we used to have a failure because those days the techniques were not that good, and repeat, you know, fistula repair used to give the permanent scar sometimes, permanent, you know, dribbling of the urine. Similarly, rectovaginal fistula, they were also, you know, many times we have seen, we have repaired, and rectovaginal fistula is the one which, you know, gets repaired very easily, and you can repair it whenever you diagnose. So you have given insight of all the procedure, which is excellent for, you know, all the faculties, all the delegates to understand. They've understood the subject, but whatever the extra points you have given about the fistula repair, they are really very recommended to all the obstetricians, and they will implement in our practice. Thank you so much for the excellent delivery.
Thank you. I think we are fortunate that the number of obstetric fistulas are decreasing. The obstetric urinary fistulas are decreasing in India, and mostly see in gynae. And as far as the rectal fistulas are concerned, I think what is important is, as Sandeep showed, that we should not be missing third degree tears, and we need to diagnose third degree tears and appropriately suture them. You took me back, long back. My first house job was in Eden Hospital, Kolkata. And on the antenatal ward, there was a lady who used to help the nurses because the family abandoned her after an obstetric fistula and 3 failed surgery attempts. And she spent all her life adopted by the hospital as a makeshift ayah. And that used to be still the story in Africa. Fortunately, in India, with our institutionalization of deliveries, we have done much better. But I think we need to focus us on the third degree tears and the gynecological fistulas. Thank you, Sandeep.
Thank you all. Thank you all for patient hearing.
I think, Sandeep, you have given an excellent presentation. In my life, I've seen very few fistulas in India, only in Calcutta Medical College when I saw 1 or 2 there. And then again, I saw 1 here in Nagpur, but my experience regarding fistula is very poor, I must say that. And the ones who have been repaired by others, they were coming again and again for repair, and it was never done very well. So it was something like, now that it's been done so nicely, I think it is really, of course, we don't see such cases because obstetric care is much better now than what it used to be before. And I think African countries, they have more fistula because they have no obstetric care, and the young girls who deliver with obstructed labor, and you hardly get any chance to see. In India, we see very few, especially if you are not working in a village centers. So I think you have done excellent work, and you have taught us something new, which I didn't have so much knowledge.
Thank you, ma'am.
Thank you.
I request Dr. Hrishikesh Pai, sir, Felicity Nikhade, sir, and our chairperson. Request sir to felicitate